Good morning, everyone. My name is Tomás Morel. I'm a trustee for the Leg Club Foundation. I want to welcome you all for coming, making a long journey, all the way to the cricket club. You got a lovely day ahead of you of, fast pace, dashing through rooms and meeting loads of people. Hopefully you'll enjoy it. But for the first workshop of the day, I have to say we have two outstanding, world-class professionals in the field to go and deliver for us. Unfortunately, both of them couldn't make it today, so we were stuck with Clare and Trudie. I know feedback forms will be available. Anyway, I'll concede the floor to them to introduce themselves.
Right, so hi, I'm Clare. I've few hats to my roles, but basically my background most recently is in primary care, nurse manager, and I run a leg club down in Poole in Dorset, and I also support the Leg Club Foundation as with some clinical advice as well. So that's me.
I'm Trudie Clark. I've been a tissue viability nurse for over 30 years now, so I'm officially in the dinosaur category of tissue viability nurses. And my current role is I'm the lead tissue viability nurse at the Cancer Centre in Cardiff in Wales. I've also been a foundation member of the leg clubs, passionate about leg clubs, and I'm just been made a patron, so very proud. So leg clubs are my thing, definitely. But we haven't got one at the Cancer Centre because it's not people with legs, really. Okay.
Great. So workshops, they are interactive. We're not going to stand and present to you. That's tomorrow. Okay. So workshops are about you being involved in the workshop. So we're actually going to make you do the work this morning. So I hope your brains are functioning, because hopefully we want this to be interactive and hopefully you'll all get something out of it, because very much appreciate we've probably got a completely varied wealth of experience in here, and you will all be expertise in your own area. So what we want to do is just try and bring that all together and all hopefully take some bit of learning away from it. So some of the stuff we might go through that you might think, oh, yeah, I know that, I'm pretty FA, but hopefully there'll be something within this workshop that you'll take away and learn, really. So obviously this is about does lack of time lead to poor care, really? And I just want to sort of get some feedback from you, really, about what is it in your working day or your working practice that actually impacts on you delivering maybe the optimum care maybe that you want to deliver? What sort of things?
Well, I work quite rural, so I work in that hospital, but in Herefordshire it's very rural, so there's a time pressure for travel.
Mm-hmm. So time, yeah. Absolutely. And I'm sure probably time is probably one of the biggest demands, and maybe not having enough time to deliver the care for the person in front of you that you want to do. So time, yeah, so whether that's related to travel or maybe it's a clinic demand, the next patient's waiting, or the volume of patients maybe attending if you run a leg club, the volume. So time is probably one of the key things. Anything else at all that might impact on your ability to... Resources? Mm-hmm. Yes, yeah. So you sort of identifying as sort of maybe that could be sort of equipment, or it might even be referral to sort of specialist services or something, because again...
So we're the specialist service, so having the
right.
nurses with the skills to pass that back to
yeah, so then you're probably leading to something else there as well, as education as well, isn't it? That's paramount. If you don't know what you need to do and you haven't got the skills.
So again, education, because the education is there, it's the uptake in education.
Absolutely, yeah. So again, it probably comes back to that time factor, doesn't it? It's about being able to have the time to do the training, as well as maybe the financial resource and the staffing resource to release you to do the training.
Also, backup and support when you need to refer out, and there's waiting lists and they can't take your referral. So it's something that you need to refer them on the treatment for.
Yeah.
So
Yeah.
that can be
So
frustrating
so that
sometimes.
demand on a particular service,
Yeah.
and maybe the
Yeah.
backlog.
Yes.
And obviously, I know we're hearing very much about that in the public domain at the
Yeah.
moment, aren't we? But you know that does impact on your ability to get that person
Yeah.
early
Yeah. Yeah.
treatment
Yeah.
or specialist
More
advice.
frustration because I've had a few patients where you get them referred, they get the appointment, and then month after month, that appointment is then, sorry, I can't see you, and it's put back another 4 weeks, and then in 4 weeks' time it's put back another 4 weeks, and you're months down the line. And certainly with cancer, you can go from somebody where an early intervention could have been curative to somebody by the time you get them there, it's metastasised, and that's terribly upsetting.
Yeah. And we see that all the time, especially post-COVID,
Yeah.
because people didn't come forward in COVID because they didn't want to come to hospital. Now they are coming to us, yes, and now coming to us late presenters. I want to just build on what you said about the referrals. Do you think sometimes within that is a process thing? Because sometimes if you have to go to the GP for the GP to refer on, when you would like to just refer directly yourself,
Yeah, and
there are obstacles then sometimes in the referral pattern, I think.
yeah, and also this silly system whereby we had a patient where we knew they needed to go straight to MRI, but they couldn't because they had to have the X-ray first. So we had to wait for them to have the X-ray, for the X-ray to come back and say they need an MRI. Then they go for an MRI, then that's got to go back to the doctor, then the doctor's got to refer to the specialist, then you've got to wait for the specialist. So in one instance we had a year with one patient, and if it had gone straight to MRI, and then it was another 6 months to have the surgery. So that, I mean, that's to me a huge waste of resources. When why can't they take our word for it that that's what needs to be done in the first place, and then you're not logging up the X-rays for people where an X-ray would be diagnostic.
That's something I find which is one time pressure for me in the cancer centre is we can get MRIs that day.
Yeah.
You know, that is so lucky, isn't it? We can't get a Doppler done, mind you, but we can get an MRI. So it depends where you work, doesn't it? But that's a very good example of time, a year.
Yes.
Yeah.
But
Which-
Wales is very good, and I mean Melanie has done so much to improve the system there. I mean, she's like a one-man bandit.
She is. So Mel, she's here. She's not presenting this time. She did last year. She is the head of the lymphedema service in Wales. Wherever you work in Wales, you have exactly the same care. The same competences with the practitioners, the same documentation, the same referral system, exactly the same across the whole of Wales. But that is because Mel is a very strong person, but also she realises that no data means no problem. So very early on she collected data. So if you're looking at these pressures yourselves, what would help definitely is the data to say time is causing me an issue because of A, B, C or D. Again, when you were thinking about, you were saying about resources, what resources would you say are the ones that the people don't have? What, any particular resource?
We've had problems getting dressings because they're done prescription per patient. We don't have the stock. So some of us aren't prescribers, some of us are. So we either have to ask the GP, and the patient's not allowed to request it themselves. It has to come from us. Because the patient could be like, oh well, I've got a few left, I'll order some more. Obviously communicating with us. So then we have to go by the GP, then that has to go to the pharmacist, and that relies on the patient then picking that up. So by the time you've done all that, you might even want that dressing by that point, you want something else anyway. But so that's kind of a really basic one, and then we obviously have quite a lot of devices that we use, and they're expensive, so we only have a few of them. We're a big team and we share maybe, I don't know, 2, so we kind of have to discuss it and prioritise who can have it and how long they're going to have it for.
And what device is that?
So we've got the Wound Express.
Yes.
We've got the Axel Heals, but again that depends on GP whether or not they'll issue it because it's expensive. Some will, some won't. So it just you've kind of got the luck of where you live, and it's, it's things like that. I'm trying to think what else we've got.
We've got Gecko, Eco. That's all we've got.
I think that's not bad.
Yeah,
Now you think about it, actually, yeah.
But again, the more you see them, you think, oh, well, they that then can't have it because you've got to wait.
Yeah.
But you know, it is you know, realistically it's the NHS. We haven't got pots of money, so.
Dressings is a difficult one though, isn't it? Because you've got an expiry date.
Yeah.
So if you're going to have a stock of them, you know, you could be having to throw
we don't have a
things
budget.
away. So that's
we don't have a budget
can
for
see.
dressings, so we have a budget for bandages,
right.
but not for dressings.
Yeah, and the irony is, in our area, we know it. So I used to work in Royston as a district nurse, and that is the GPs are commissioned by Cambridgeshire Partnership Foundation Trust. So the GPs get a massive stock of dressings. So the district nurse dressings is vast, and it works. And they very rarely, very rarely will they throw dressings out because they were used so much. And when I then moved over to HCT commissioned GPs, the district nurses did not have that dressing supply, and we do not have that dressing supply. So there is that issue as well of being able to, if you see someone that's got an infected wound, realistically you want to put that antimicrobial on almost straight away to avoid that becoming systemic. And if you can't do that, there's then that issue there. So yeah, I think the GPs do need to, I think we need to kind of get a system that is better with regards to sourcing dressings. But in our clinics, we have a basic stock, and what we generally have to do is order extra for patients to then kind of replenish our own stock from what we've had to use from our clinic stock. It's basically we just have to keep an eye on what we've got.
You have to work smart.
Yeah, we do really work smart.
Yeah.
But ultimately, it's about using resources effectively, isn't it? And so that you can.
But it highlights the postcode lottery, which doesn't happen in Wales. So if it can work in Wales, it should be able to work everywhere else.
Yeah.
So I'm going to say similar. So in Dorset, so I'm because I'm a strategic lead across Dorset. So we've actually pulled together everyone from all the different disciplines, and we're actually now going to have a pan Dorset approach to lower limb care. So you can do it. You can do it in your area, and hopefully you might learn some of that tomorrow in the presentation. Really. So. Is there anything else that's burning that you think really impacts on your ability to deliver care? So we've talked time, resources, some of the referral processes, and all of the bureaucracy that comes with that, and the long delays. So there are certain things that might be outside of your remit, but obviously there are some things that maybe you can change. So one thing that we were sort of really wanted to focus on was about that initial assessment. Now again, we've got, we've got experts within the room here, and so, but I just want us to all sort of now to sort of think about that initial assessment and how can we really make that fully holistic and cover all the aspects. So that hopefully we can highlight problems as early as possible. So what we'd like to do is to put you into sort of groups of 2 or 3 and each give you a bit of an area of an assessment, and just to talk amongst yourselves and think about what are the things that you would look for within the areas that we give you, and then ask you each just to feed that back. As I said, we want you to be interactive, and then we'll bring that together really. We'd probably like sort of five groups. Now I know you don't all know each other, but by the end of this morning and by the end of the day, you will know each other, because you'll be doing probably getting to know each other as a group. So now's your opportunity to get to know each other. So ideally, if you are here with a work colleague, maybe go in a different group so you get to know some other people and we share the expertise around the room. Is that okay?
So who does work together? The ladies at the back and the ladies here. So if you could, one of you swap?
Yeah.
So just going to ask you just to swap, just for a little bit. You can come back together in a little while, so don't be too panicked about working separately. But just it's nice to get to know and hear. We've already heard already about the differences, the postcode lottery, that we all work very differently, and the resources and the staff and demand is very different depending on where you work. So it's good to hear about other people's areas and have that input. So sort of 5 groups of sort of 2 or 3 people, would be great. So if maybe we could just sort of shuffle you guys around.
I'm doing the I'm doing the audits for the workshop.
Okay,
So I don't know whether you want me in a group or not. But
Please do.
Are you
yeah.
not?
I'm happy, yeah.
Be part of it. Yeah,
So,
be part, absolutely, absolutely. Everyone adds value into that.
Excellent.
Unless you do, unless you work with Keith. Yeah.
Keith, you two together?
Are you okay? Are you all right?
I don't know anything about the field. I'm just observing.
Are you all right there?
So I think it's two.
Oh, this lady's not clinical.
Oh, okay. So there's 3 and 2 and then 2. Brilliant.
You're going to give out the subjects?
Yes.
Okay.
Yes. Right. Ladies are getting to know each other. Brilliant. That's brilliant. So I'm going to ask you to look at predisposing factors and risk factors. So what I'd like to know is what is it? You know, what are you looking
Claire will
for
give you a
under those
specific
2
area to
remits?
discuss,
Okay.
and how you would involve in your assessment.
Patient in front of you with a lower limb wound. Yes. Yeah. Okay. So scenarios, you've got a patient who's first presented with a lower limb wound. Okay, so that's your scenario. All right, and I'm just going to give you specific areas just to look at. If you guys can look at what observations you do for them, and looking at what might be the any presenting factors, anything that might be that they're presenting with. Okay.
The red flags.
Sorry, what I was going to also add into yours was with the presenting factors, also the position of the wound. So thinking about how you
The site.
the site, not the actual wound, the site. Ladies, right. So can I get you to look at pain assessment, chronic edema, and foot assessment? Okay. And then ladies over here, if you could look at the wound assessment, so the actual wound itself, what are you looking for when you're looking at a wound? And also, what additional information would you be looking, sort of that's outside of the wound and the presenting patient? Yeah, okay.
10 minutes. Or 5 minutes.
5 minutes.
Yeah.
Won't need longer, though.
Because in a sense we don't have to do this.
No,
We'll just chip in, chip in
as we go through. Yeah. So we're just going to give you 5 minutes, so very, very
I think as well, Claire, we're very experienced.
Yes, they are.
So I don't think we'll have to chip in with
No, I
two.
don't think we'll have to chip in much more. That'd be good, because maybe you might want to do something to say about pain. Like
Pain,
one of the
I'll get mine out because then I'll know if there's anything on there that I've missed.
not missed, yeah.
We do that for normal obs as well.
How you doing? All right. Yeah, getting a good list there. Fantastic. Yeah.
It's that confidence, isn't it? People think,
How are you doing, ladies?
Just because they're there, obviously look at
Claire and I were just saying we've got a very experienced group here, so we expect a marvellous answer from each group.
Yeah,
Because I think
hopefully
it's, you know,
bread
it's
and
your
butter
bread and
work.
butter what you're doing every
You've got the
day.
good one.
You're okay, yes?
Yeah.
Are you okay?
Yeah, so with regards to, I think she was asking us where the site was of the wound, and then also there's a little list.
Observations.
Observations. So we're looking at the visual observations as well as our baseline observations.
Mainly baseline, I think we're after.
So
We're after.
Just go around observing.
Yeah.
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 What was the other one that she asked?
What are you doing?
Editing videos here.
Oh, okay, right.
Was it presenting factors?
Yeah. So that's, I guess that's what we were
Trying to see the
That kind of stuff, yeah.
what people are. Yeah.
Hopefully make some connections.
Fire
There
away.
you go.
Interested in writing.
It might overlap with some other groups, but that doesn't matter. So you're auditing today.
Okay, that's fab. That's fab.
Editing videos here.
Yeah.
How you doing, guys? You all right? Yeah. Yeah. And I probably gave you a bit more challenging one.
Hopefully make some connections. Learn how people deal with it. See if somebody would be interested in writing about some of these talks. Because we do the chronic food supplement every 3 months.
Yeah. So which company again?
That's British Journal of Community Nursing.
Yes.
Their supplements, CWC. So that's what I'm looking for.
Yeah.
Because I'm new to the role and to the industry, so I have the connection and I can help all the people.
Oh yeah, you'll make connections here.
Oh
Yeah.
gosh, you'll have to go. I think there might be a few
I'd
reds
say
around.
nearly everybody who is presenting
Oh, of course you are.
in the
Of course you are.
workshops
Sorry, I've
and the
just
main
got that.
published. Nearly
Get one of those ergo
everybody.
pens.
Yeah, very
How you doing?
experienced
You
group
all
of
right?
clinicians.
Yeah.
So we're looking at the varicose veins.
Perhaps get to know. I do, but I've stopped. I've written for years, so I don't write anymore. And the other thing, I have to be totally truthful with you. The other thing is that the amount of effort it takes to write and the
Just give you about 1 more minute,
compensation
guys.
don't match. Especially if you're going through a very good piece, that doesn't match. So that I think is a problem for you, isn't it?
The first thing I noticed when I took over, I looked at the budget I had and said, how am I going to commission good quality articles in just this amount?
That's it.
And you
It's a
need
challenge.
a lot for every issue.
So in a sense, perhaps the audiences that you'll work with, listen to who seems to know. And we've got a very experienced group in here. And also it's coaching them to, if they're new to writing, sometimes it can be a big step. So that's, And we're welcome.
Exposure for them.
Oh, it is. Oh, it is. Yeah. For CVs, it's very good.
Don't know what you don't know, do you? Absolutely.
Thank you.
Are you all right, ladies? What are you looking at? Oh, well. There we are. Oh, you got an easy one.
Well, yeah, exactly.
Yeah,
It's just as simple as measuring though, isn't it?
yeah. Have you got a wound assessment chart that you use?
Really? We just sort of use the times
Yeah.
as a
Yeah.
Hopefully it will come out in as we keep out, and it can obviously
we just use
offer.
System 1, which comes up with all what we
Ah.
need. So if it's deep, do the depth, record the width, make sure you're recording which ulcer belongs to which
Yeah. So you use system 1. Okay.
Right. Shall we
Yes.
start to sort of pull it all together? So. Okay. Yeah. So what we're going to do, if you don't mind, and we're only a small friendly group in here, we're just going to ask each one of you just to feedback. And obviously, this is not right or wrong, and everyone's going to have. And please, everybody can add in as we go along, because there might be something else that you think about that might be under that. But it's just trying to think of that sort of logical, holistic assessment. So you've got your patient, your person in front of you, and let's call it her Marjorie. She's 68 and she's presented first, with you with a lower limb wound. So let's go to group 1, and we gave you sort of predisposing factors and risk factors. What sort of things are you looking for in that?
Well, we were looking at past medical history and other predisposing factors like obesity, arterial and venous status for that patient, whether they were diabetic, what their age was, whether they were living alone, whether they had support, their ability to comply with any treatment plan, and was that linked on understanding difficulties or dementia, etc. what their mindset was towards the treatment, what had brought them there, etc. Ongoing community support, we were looking at it like we were a specialist centre, and what we wanted to happen, going to be supported by the local community and GPs, what the time frame was going to be. We looked at delays perhaps in prescriptions from chemists or GP surgery. I mean, I've personally had experience of chemists having distribution centres rather than being signed up directly to companies, so ordering became a problem for certain products. And also within the GP surgery, depending on, we've got 2 different systems in Hertfordshire, and some of the staff in the surgeries can't actually access the system, so they're saying to patients it's not available on FB10 when it is, they just can't get into the system, so that's sort of frustrating. So again, that was going to affect their diet, again, how that was going to impact. And also, you know, probably polypharmacy, were there other things that they were on that had caused issues, or did they need other drugs that would help, you know, were there infections, were they on long-term antibiotics, or were there other treatments that could be applied?
Mm-hmm. Great, brilliant. So very thorough there. Anything else that anyone else would look at within there?
Previous surgeries and family issues.
Yes.
Yeah. The only thing, sleeping. Do you ask about sleeping? Do they sleep in bed or do they sleep in a chair? Just, you know, from my experience, you know, a particular person that stands out in mind, and we really couldn't understand why he wasn't healing with all the care he was getting. And it was discovered that, actual fact, you know, his wife didn't want him in the bed because his wounds were smelly, leaky, as they are. But and he was in his chair overnight, every night, and it was a gentleman in his 50s, when you would expect, you know, potentially that with all the care that was going, that he would, you know, would heal. But actual fact, because he was sleeping in his chair, his legs were down all the time. So I think, you know, sleeping may be just another thing to add in there. And how do they sleep? So not just do you sleep at night.
Yeah. You mentioned diabetes as a particular medical condition. Are there any other medical conditions that come to mind as well as diabetes?
Venous insufficiency.
Yeah.
Arterial problems.
Yeah.
RA.
RA. Yeah, that's the one I was hoping you'd come up with. Grand.
Lovely.
Yeah,
Thank you.
Very thorough.
Very thorough. Well done. Come to you guys. Okay. So I gave you observations and presenting factors, which there may be some overlap. Don't worry. That's fine, because we're all thinking on the same lines.
Yeah, but
so
also the site of the wound as well, so whether it's actually the lower limb or foot, and with regards to those referral process as well, who we refer them on to if needs be. You present, in fact, the baseline OBS, we want to know if there's any systemic infection. The baseline OBS are all good. And also the visual aspects of the wound as well. We need to know the chronicity, how long that's been there for, that wound's been there for, longevity, the depth of it, the surrounding skin, the edema, whether it's redness, the hemosiderin, all those visual observations that we need to be putting in place. Involving the patient along with this all the way along, just so they've got an understanding of why we're doing this and what for. Looking if there's any critical limb ischemia within regards to that, and those flags that light up with us, the leaky legs, the arterial insufficiency. Yes, that is our list.
Yeah. So looking for sort of signs early on, whether there's, you know, something that an underlying cause, isn't it? Really.
Yeah. Differential diagnosis as well.
Yes.
For that between the venous and the arterial.
Has anyone else got anything else they'd put in there?
Any other observations?
Any other observations?
We said we might take a picture of it.
Yes.
That's absolutely great. Yeah. And Doppler?
Oh yeah, Doppler at that point.
Yeah. Doppler, if you've got, you know, if you're able, you know, to do it there and then. But this is about providing, you know, hoping that you've got, you know, the time for that initial assessment. So obviously having that Doppler to help.
Along with the photograph would be measurements and making sure that your measurement was from a set point. So you were always able
maybe
to
come on to that in our next.
As well, because we were doing limb measurements as well.
Yeah.
Should we move on to the next part? Because obviously all of these, you know, this is about a full assessment, really. Yeah, absolutely brilliant. So we gave you sort of pain assessment, chronic edema assessment and foot assessment. So
we didn't even start the pain assessment. Chatting about the rest. So because obviously we work in different areas, there's different services. So 2 of us would refer chronic edema to the lymphedema team if they didn't have wounds. 1 of us doesn't have that and have to do it themselves. So we would do things like, so looking at the chronic edema, so a lower limb assessment, so your measurements, your Doppler or your TPI depending on that, and then obviously looking at other things, so is there heart failure going on, what's causing the edema, like you said, are they sleeping in a chair, are they not, and then we were thinking we would do a lot of kind of education, about exercise, skincare, and then obviously most probably, depending on the findings, compression, and then working out how they're going to get that on, who's going to do that for them. So that was, I think that's all we put on there. And then for our foot assessment, again it's difficult, depends on where the wound is. Our service wouldn't see a foot wound. However, if they're a housebound patient, podiatry won't see them, so then we have to refer them to tissue viability, and they will see them. But it's just we haven't got that service, but you guys have, so they're really lucky. But we would say that we would do TPIs, referrals on if appropriate, but we would be looking at skin changes, temperature, their nails, their wounds, and their cat breathe feel possible, need for X-rays, like foot shape, if they've got shark holes, whatever it's called, is that right? I think that's all we put, but
yeah,
we
okay.
talked so much.
Okay, no, that's fab, and I'm conscious of time, and I'll let Trudie come in with the pain side in a moment. I'm just trying to reflect a little bit back. It was just interesting, and this is not a criticism, please don't think, would refer to lymphedema. How do you know it's chronic edema? What is it that you're recognising?
Well, even get the referral review come through to us.
So no, but this is a lady that's presenting with a wound.
So we would treat her.
So look at the shape, the shape. Look at the feel the skin. So that's stuff that we can all do. So this is not about having, I think one of your workshops will be, the lymphedema experts. Yeah. Absolutely. So we're not looking at you being the experts, but it's about recognising those early symptoms so that you know that you need to refer. Foot assessment. Quick, some of you may be familiar with using, monofilaments. But do you also know about the touch toe test, the Ipswich touch toe test, which is something everybody can do. So, that's literally holding the first, third and fifth toe. Hopefully they have all 5 toes or thereabouts. You can reduce it if they have less. Holding it for a second or 2, and do that on both feet. Can they feel each one? If there's 2 or more that they can't feel, then they've got reduced sensation. And that's actually that's a recognised test from the podiatry. It was Ipswich Hospital that did it. So that's something we can all do. We don't need to know how to do a monofilament. We don't need to refer to the podiatrist at that point, because we're not necessarily saying there's a wound on the foot. But yeah, absolutely, the other things that you picked up, look at the nails, look between the toes, have they got a fungal infection? Look at the heels, is there cracked heel? Because as much as I completely agree, we do have, it's one of my frustrations, I'm going to say, because I feel the foot is attached to the leg, and most of the time the leg is attached to the foot. It's a whole limb, and I think it's trying to think about the whole limb. We're not saying you're experts in podiatry, but it's really important that we care for the foot, even if we're looking after the wound on the leg. And the same for the podiatrist. If they're caring for the foot, they need to be aware how to look after the limb. And that's one of the things, the works that we're doing, is bringing all of that together so that everyone has some core. Next door, so you can pull them in. But I think for everyone, it's about having that awareness of what are the things that might cause problems. I'm going to hand quickly to Trudie about pain, and then we'll move on to
conscious of time, and we've got the final group.
So should we do the final group first?
I
and
think
then talk about pain?
Because I want to hear what the group has said, and if we've time.
So you had a wound assessment, and then the additional information, which some of them we've probably mentioned, but please tell us about wound assessment.
So we would look at the general presentation of the wound first, whether it's coagulating, epithelializing, or it's completely slough. We'd also look further afield at the peri-wound. Is that dry, macerated? Is it varicose eczema?
Just warning us.
We consider if there was an odour to the wound. If there's an odour, do we think it might be infection? If it's infection, we would stop it, we would do obs. We consider the exudate, the consistency of it, the colour, the amount. And we would also consider the general leg and foot appearance, the colour of the whole limb, whether it's edematous, whether there's any hair loss. I think that was really it, wasn't it? And then we'd also consider the patient's general lifestyle as to how, whatever we decide to do with this wound is going to affect their lifestyle, if there are any factors within their lifestyle that are going to affect how we treat.
Exactly, isn't it?
And pain as well. Is there an increase of pain? And when it comes to the size of the wound, in our area we started working out percentages, so we can work out the percentage of the decrease or increase, which gives us a really good idea of how well this
so it's a baseline, isn't it?
is healing. Yeah. So there's that.
Great. Well done. Thank you. Yeah, absolutely. We said that. Yeah. And think about work. They might be working. What's their occupation? Yeah. Very briefly to Trudie, and then we're going to summarise.
Okay. So on pain, we were just saying we'd use a validated pain assessment tool. Obviously, with our diagnoses, we're coming up with your arterial pain, your intermittent claudication. With venous, you've got that heavy swollen leg pain. Is the pain on elevation? So is it there at night if they are going to bed? And again, pain is quite often what makes people present to us in the first place, is the pain, and they expect us to do something about it. We need to know, don't we, is it background pain? Is it pain during dressing changes? Is it there all the time? Can you distinguish it from the pain of their underlying arthritis? So, and again, we treat pain differently, don't we? So nociceptive pain, stimulus response, we start with paracetamol, brufen and work up the pain ladder. But if it's neuropathic pain, we're looking at gabapentin and pregabalin. So we've got to distinguish the pain, and we tend to do that by the way they describe it to us, don't they? Your neuropathic pain, stinging, pins and needles, yeah? So we need to get them to verbalise the pain and where it is and how long it's for.
Great. Okay.
And also, pain is subjective.
Oh, it is.
And if you have a high threshold to pain, what I've found in practice with some patients, they're not taken seriously because it's considered they're not in enough pain for that particular condition. I have one with Durkheim's, for example, and pain is so subjective. You've got a high, so you say the pain scale, but I think it's always worth thinking about that and not letting that define your treatment of the person.
Well,
you made a really good point though about looking holistically, because a lot of people, with greatest respect, they're looking at their discipline and not the whole. So fungal infections.
If I could just summarise, you're great. Thank you very much. You're doing it for me. Brilliant. So just so in summary, the idea is, we talked very early on about all of the pressures, and one of the biggest things was the big T, time. Time for everything, whether that's, time to see your patient, time on your, the impact of resources, etc., etc. So time is biggest, but if you can invest the time early on and do that full holistic, and we are, as I say, we're not expecting everyone to be an expert in lymphedema, everyone to be an expert in foot care, but if we can consider the basics, and I think you've all come up with some fantastic things that you would look for, an early recognition of whether there's an underlying arterial problem, an underlying vascular problem, and where you can get early. So that full holistic assessment, looking after the whole limb, even if it's not your area of domain, thinking about the whole limb, but also that limb is attached to the person and that whole person and all of the factors that you've all brought up that affect that person on a day-to-day. We need to consider all of those, and including, what their perception of pain is, what their expectations are. So hopefully that just to summarise, it's about doing that full holistic assessment. So thank you very much for your participation. It's been great listening to your feedback, and hope you enjoy the rest of your workshops. Thank you.
Thank you very much.
Thank you.